Can people hear me all right now? Sound proper?
Yep.
Yep.
Sounds
Yep.
good.
Good. Hi, Carolyn. Nice to have you along. All right, so this is a special event, a monthly event that we have for the Health Professions Education Special Interest Group of the Society for Medical Anthropology. Our mission is to support anthropologists in making a positive and lasting impact on medical and health professions education by creating an organizational space that nurtures healthy professional identity, promoting lifelong career advancement, and serve as a representative voice for anthropology among health professions and the public. And that is our contact email there. As we go through here, we're going to be mentioning several initiatives and also ways to contact us. And that's the email address for the Society for Medical Anthropology, SMA, period, SIG, period, HPE, gmail.com. And we also have a webpage, which is listed there also. And an easy way to get to that is just go to the Society for Medical Anthropology webpage, drop down menu for the interest groups. And where listed there is the HPE, Health Professions Education Special Interest Group. As we go through here, the chat is open. Can you see the chat? Yeah. And that's where you please type in your name and your affiliation and email address so that we can kind of have an idea of who's here. And as we go through, we'll have a question and answer period after Jason speaks. And by having introductions over there, people may feel more free to talk with one another. Yeah. So I am Dr. Dennis Weidman, an emeritus professor of anthropology from Florida International University in Miami in the Department of Global and Sociocultural Studies. Our interest group co-chair, Iberis Martinez, is not able to be with us today. So she normally co-hosts these with me. And so today we have Richard Gonzalez, who has been a very active member in our SIG. Our SIG is only 17 months old. It only started in November of 2022. So Richard's come along and helped us out in quite a bit. Richard, would you like to introduce yourself briefly?
Sure. Hello, everybody. I'm Richard Gonzalez. I am Associate Professor at the Philadelphia College of Osteopathic Medicine. I have been in medical education for, 13 years now. So spent half of my career, my early part of my career teaching anthropology students, and then I made the transition early on, starting with a PT program, then moving on to PA, combination of those, and then ultimately medical education, where I have been since.
Yeah, very fun. Thank you. And so Richard's going to be co-hosting, admitting people, and if you post questions over in chat, Richard will be monitoring those. Some of them may be appropriate to then speak up and have Jason answer immediately, or delay till our question and answer period. So our special interest group, we now have a listserv. That's how we communicate with most of our people. We have over 250 people registered there and signed in from over 60 countries of the world. We also have a LinkedIn public page for all kinds of people of professional interest with 105 people. We have a web page open to our members where we have resources, events, and initiatives. And some of our most important initiatives are once a month presentations like this one. And all of them are related to educating of health professionals and the way that anthropologists can be influential in doing that. Those are usually recorded and placed. The recordings are placed on our members' webpage, so you can go back and you can see the ones that we've had in the past. Some other initiatives is we're trying to identify training programs that train anthropologists for careers in the health professions. And so academic degree programs sometimes could be specialty programs in organizations and companies. So if you know of a company or your own program that you would like to have profiled here and on our webpage, that would be a thing to do. And you can help by just sending an introduction to the email address that I shared with you. And also what we're trying to do is bring health professionals, anthropologists who have been in the health professions for many years, aren't usually related back to the profession of anthropology. So this SIG is meant to draw those people together and to build a cohort and recognize them in their careers. And so for people who are in health profession careers, who are in a training kind of a role, we would like to profile you and your career also. Another kind of initiative we have is we've just started profiling specific health professions. And so this is a way to bring information to the public. It'll be posted on our webpage. And the webpage at the moment is kind of an internal webpage, but the external webpage will be developed shortly. And so these public statements about specific health professions will enable people, academic departments or individuals, to share very short statements, 2-3 page statements, to your own health professional. It could be even your own doctor, letting them know what anthropology does for the health. So this is our way of generating public information to the benefit of our profession. And another initiative we're just starting is the competencies. What are some of the skills and competencies that anthropologists need to have in order to gain access and to be good at their particular health professions? But also, if we're training health professionals, doctors, nurses, what are the kinds of competencies that should be in those curriculum? And so Richard, by the way, is our leader of our competency skills initiative. All right, so let me now move to so our speaker today on clinically applied anthropology, medical anthropologist in biomedical systems, is Dr. Jason Wilson. Jason is a physician, medical anthropologist, and chief of emergency medicine at Tampa General Hospital. He develops patient-centered pathways that are medically efficacious while considering structural and cultural forces in determining health inequities, and disparities. This approach reconsiders the role and position of the hospital emergency department and how medicine can address social determinants of health by creating new assemblages of care and placement of anthropologists directly into the clinical space. His 2022 co-edited book with anthropologist Roberta Baer, Clinically Applied Anthropology 2.0, Improving the Patient Experience Through Education and Integration of Medical Anthropology into the Clinical Space. This book presents an applied medical anthropology that engages with clinical spaces, healthcare systems, care delivery, and patient experience, public health, as well as the education and training of physicians. Jason received his PhD in anthropology from the University of South Florida in 2023. He is currently the chief of emergency medicine at Tampa General Hospital, and he's chair for the newly created University of South Florida Department of Emergency Medicine at the Morsani College of Medicine in Tampa. And so, Jason, we thank you for being here and anticipate your presentation. So let me now share the screen with you.
Thank you, Dennis. I appreciate everybody for being here and for you to invite me. Dennis and I virtually were together at the SFAs just a couple of months ago, and I gave pieces of basically this conversation in a panel that Daniel India put together. And so some of this will be pieces of that conversation today. And then some expansion on some of the other work, and with a little bit of focus, given the focus of this interest group also, of where I sort of see anthropologists being able to really position themselves into the biomedical system in a way that maybe they haven't thought of so far or haven't really done yet. I think there's a lot of opportunity there for the anthropologists, the medical anthropologists, to still position themselves in biomedical spaces in unthought of ways that are really untapped at this point. So I'll get into that as I have the discussion. To Dennis's
All right.
point,
But Jason, may I clarify?
please.
Can everybody see Jason? Because I can only see my slides that I had up.
Yeah.
Jason, your
I
slides
can see
visible?
him and his slides working
Yeah,
fine on my end.
We can see his slides.
Okay.
Okay, you should see a white PowerPoint slide that just says clinical anthropology right now.
Yes.
Okay, okay. It's all stuff you know, Dennis, so it's okay if you can't see them. So yeah, to Dennis's point though, and I can't see the chat very well, so it's totally fine. I mean, I'm an ER doc, every day, so I'm used to being interrupted many times a minute, so it's totally fine. Interrupt me and ask questions or shout things out, or ask Richard in the chat, and he can relay them, or we can wait till the end. But either way is totally fine. I'm going to go through a little bit of the story as to how I came back to anthropology after a bit of a journey, and sort of how that journey back in anthropology then led to a current place where I sit, which is really to try to bring on anthropologists into my faculty to continue training both physicians, students, but also other anthropologists to do this kind of work, and what that journey looked like, and how we got there. So let me go back in time a little bit. I'm going to leave this slide up as I kind of go on a time journey here. I actually started out in my undergraduate career wanting to do anthropology. So I was going to do anthropology. I went to USF. This is in the mid to late 90s. Was an anthropology major. It's actually where I met Roberta Bear, who's been my longtime collaborator. Went off to graduate school at the University of Michigan, started doing some biocultural anthropology, but kind of got an itch to go to medical school, really based around the work of anthropologists who were rotating through our lab. I worked with Roberta Fersancho at the time, who did a lot of adaptation work and anthropology. And we actually had emergency medicine physicians rotating the lab with us, and sort of introduced me to this concept of, perhaps I could do some of the work I wanted to do and some of the research I wanted to do in medicine, and still integrate some of the anthropological lens. So I left, I made it to candidacy. This is around 2004. So I came back to medical school in USF, went to medical school, really with the idea that I would finish my PhD when I first started. But, life is life, things happen. And things, of course, take longer than you think they're going to take as you jump into the decade-long training that is biomedicine. So came back to medical school, did my undergraduate medical education. And when I say undergraduate medical education, I mean, of course, medical school in the parlance of medical education, meaning undergraduate medical education being the 1 through 4 years in medical school, and then graduate medical education being the residency years. I'm going to come back to that in a few minutes in this talk and talk about some opportunities there too. So did my training, 4 years of medical school, 3 years of residency in emergency medicine, stayed on as faculty eventually, and came on as the research director for the program. And it was about 2 or 3 years into that I sort of recognized that I really needed and wanted to reintegrate anthropology back into what I was doing. At the time, I thought there was a real, there is an ongoing epidemic in medicine right now around burnout, around physician burnout, and the role of what the physician is in the healthcare system, right? Healthcare continues to kind of undergo major neoliberal shifts and forces of capitalism, and the physician role in that continues to move around as well. And so I've sort of been, from my training into my life, professional life, kind of watched that play out. and sort of seeing how that affects physicians themselves, but also patients, and where patient experience and where patients live, and that kind of get lost in that mix of delivery became really interesting to me. Around that time, I had run into Robbie Bear, and we had started talking about things again around this concept of patient experience, and where patients sat in this modern day healthcare delivery system, and got interested in thinking to ourselves, maybe we could educate future physicians in a different way that might give enough power to sort of change the way medical education and medicine was delivered in the future. And so from there, we started talking and building an undergraduate course. And we actually built an undergraduate course for mostly anthropology students, but also honors college students who were highly likely to go to medical school. And the thinking behind that course and the structure and the strategy of that course is really that if we can sort of get at people who are likely to go to medical school early in their preclinical training, could we set a seed? Could we plant a lens? Could we, give the person an early perspective they would keep throughout their entire training around what the patient experience looks like from a culture and a structural lens? I would say early, this is now kind of the mid 2010s, right? 2014, 2015, kind of thinking about things at that time, really still thinking about the culture concept a lot, and trying to figure out where that fit in modern healthcare delivery. And I'll come back to that in a minute, because I think as that shifts around, so does the role of where we can exist as anthropologists and train future medical students. So we put this course together, this undergraduate course. We ended up teaching it for 7 years. And that course really brought early undergraduates into the clinical space. And with the idea that they would conduct qualitative research. All pre-medical students want to do research. And one of the hardest places to do research is in the clinical space. So to have access to the clinical space meant that we, and to have access to a physician, which means they could shadow, which is also a requirement of medical school, meant that we all of a sudden had a lot of people want to take this course. And so thinking to ourselves, we'd have 12 to 15 people or so want to take the course. We ended up with, over 100 people who applied to take the course. So we taught this course for 7 years. Every year we would do sort of a group qualitative mixed methods project, sort of based around patient experience, trying to improve the patient experience, and then over time kind of watching that change. And I'll explain what I mean by that. So again, when I started with this with Robbie, it was, I think, very much grounded in Kleiman's ideas of the mismatch between illness and disease. And if we could just improve those communication styles and gaps, perhaps we could create some common ground there. And I think that early concept of culture illness in biomedicine, those sort of that disconnect is really what drove a lot of clinically applied anthropology in the late 70s and early 80s. So there's the Kriesman and Meretzky book, and I'd say that's kind of what clinically applied anthropology looked like in its first go around. Really, it was about there's a physician model of things or a healthcare delivery model of things. There's a patient cultural concept of how disease or how illness works. So disease and illness, how do you link these two things together? And I would say critically looking at that, really driven around how can you get better patient adherence or compliance to a biomedical plan. So I think that's where things were really focused on in the early 80s and into the 80s. And then I think maybe rightly so, there was a critical approach or a critique to this, a critical response to this that occurred later with the CMA movement. So Shepard Hughes and others, right, sort of come in and say, really, all this early 80s, late 70s approach is considering is how to make patients better adherence to biomedical wants, needs, desires, and approaches to delivery. So I think a lot of those critiques were accurate or were fair. I think what the most driving critique is, I think something for us as anthropologists to sort of get our heads around and maybe have some tension with, is also culture may not explain the health inequities and the asymmetries we see in healthcare outcomes most of the time. Instead, other things may explain those health inequities and healthcare outcome differences most of the time. Things like power asymmetries and poverty and homelessness and other structural determinants. So I that kind of ends the first sort of movement of clinically applied anthropology in the late 80s, right? Things kind of get sort of change. The focus changes in medical anthropology towards this critical approach, recognizing that there are likely other drivers where we see these asymmetries developing, and those drivers are structural. In the background of this, there's a movement going on in medicine, though, around the same time, and it's to really commodify a lot of what the healthcare delivery experience looks like, and it's very similar, I think, to what's going on in education over the last maybe decade, 5 years or so, happened in medicine, or is still happening in medicine, but started to happen in medicine in the early 90s as well. And that's the movement around patient satisfaction and patient experience. I'll point out that Erwin Press is an anthropologist, a medical anthropologist, and Erwin Press's work around patient satisfaction is still the brand name status bearer of how we measure patient satisfaction and patient experience. So the Press-Ganey survey is actually tied to medical reimbursement and remuneration, and even penalties around not performing well in those standards. And so we start to see this concept of how does the consumer, right? Because that's really when you start to think about patient experience satisfaction from a measurement lens, I think we start to see a shift to consumer. So that's sort of happening in the background. And then I think the pathway out sort of comes really with Paul Farmer. And that pathway out is, of course, the pathway of structure. So while his pathway of structure is a little bit different than I think how maybe Hansen, Metzel, myself maybe look at this, because it was very, Paul Farmer's approach is very patient encounter specific, right? It's the structural violence that leads to that patient encounter at that moment in time, be able to access whichever resources and have what healthcare outcome, versus maybe a larger system approach to structural determinants, perhaps. But I do think that was sort of the pathway out. Recognize you could do, I would say, applied work in the sense of him being a physician, right, delivering healthcare. Also translational work in the sense of doing the work of medicine, right, in a way that recognized there was some good that comes from medicine, right? Some drugs do save lives, but at the same time having a critical lens towards it. So in my mind, that was the pathway out. And that's sort of when me and Robbie were teaching the class, all those things were sitting. Taught the class for 7 years, COVID shows up. It's kind of hard to teach a class to undergraduates in the middle of an emergency department during COVID. And so we sort of sunsetted the class at that point, but then really documented the work of that class in the book that Dennis mentioned, the Clinical Anthropology 2.0 book, which really, I think, walks through a lot of what I just talked about, but also some real case examples of how we do this. So I want to make sure people understand, like, where I think traditionally, we think of the role of the anthropologist in the medical system as being the educator of undergraduate medical education, right? The MS1, MS2 years of undergraduate medical education. I think there's a much bigger role that anthropologists can play. So this is just right from the book. In a consumer-driven model of healthcare delivery, however, it is not acceptable or possible for physicians to structure an ED encounter to their own model of how the visit should go. Instead, the encounter must mutually unfold as a shared unraveling of why the patient came to the ED, and how best the physician can help navigate differences in explanatory models of disease and illness. That holds up still. That holds up, and also I think translates to these measured metrics that we still are held to. Leapfrog, for example, is essentially a nonprofit organization that grades hospitals. This is a big deal for hospitals because these results are public, and they are used to drive behavior for how people choose which hospital to go to, or even how big partnerships choose which hospital system or healthcare system to partner with. Of course, CMS, the Center for Medicare and Medicaid Services, also applies this type of metric to hospitals. They apply a star rating. So there's a star rating that's given by CMS to the hospitals. So these are a big deal for hospitals. They've sort of developed in the last decade and a half or so. They lead to differences in how hospitals are paid, but they also present opportunity, I think, for people who have expertise in understanding how to navigate that gap between physicians, patients, administrators, the bureaucracy of healthcare delivery. How can we navigate and move around those gaps and educate people to live in those gaps? These are just some, again, I think a lot of this leads to a real mismatch in what physicians think they're showing up for work to do and what is actually happening in the healthcare system. And this is just around the time we were writing the book. A person who has quite a bit of followers on Twitter or whatever it's called now, just an emergency medicine doctor, you can get a sense of this frustration and burnout as this person kind of reconciles the what they think they're at work to do, what they think an ER doctor is trained to do, versus what an ER doctor is actually having to do around social determinants of healthcare and around their actual job. So this is all very real, I think, still right now, that the patient and the physician, I think, sometimes have as many gaps with healthcare delivery as traditionally maybe we thought of as the patient having with healthcare delivery in the past. All these gaps, I think, are ripe for research and navigation. And I think they translate tangibly as places where you can live in the realm of patient experience and improvement of patient experience. That's a tangible, objective place, I think, to live as an anthropologist. So what is different about what we're doing, what we're trying to think about now versus the clinical anthropology of the 80s? This new clinical anthropology 2.0 really affirms that medical anthropologists have value inside the clinical space by providing a lens to recognize structural determinants of healthcare, which we'll get to a little bit more here in a second, and the recognition of the provider, patient, and healthcare system culture. So if we think of each of those things, maybe even having their own culture, also with its own structural determinants themselves. We think about structural determinants sometimes as just the patient and what predicts the patient coming to an encounter. But I'd also offer these structural determinants are also around the healthcare system itself. Insurers, ICD-10 codes, all of those things are also structure that drive how we build out clinical pathways, how we develop clinical pathways, and how we see patient populations and see care. They're also the ways that providers can maintain careers or become burned out, is based on those structures as well. So we should not limit structural determinants to just the patient. We should also think about structural determinants across the entire healthcare system, which I think helps us escape the critiques, perhaps, of the role of clinical anthropology from CMA in the early 90s, that really by looking at all of biomedicine this way, we are applying a critical lens, I think, to the entire system and trying to figure out how to improve the overall system for everybody who's wrapped up in it, which really is at some point going to be all of us. I think a landmark change to how we can approach education around structure and around what the role of the anthropologist is in medical school training is really Hansen and Metzel's work around structural interventions and structural determinants. If you haven't seen this article, I think it's an important one to take a look at. Also written by two MD PhDs, so having some clinical understanding of the world, but also social science understanding. Helena Hansen, of course, being an anthropologist, and Metzel, a historian and a psychiatrist, both psychiatrists in their clinical work. But I think this is a great example of how to start to develop a structural curriculum and challenge students to even think about when should we invoke culture versus when should we make structural explanations. The place I would go on top of this is how can we also utilize these structural interventions and structural lenses, not just for the patients, but also for the entire healthcare system and delivery of healthcare and the healthcare system. So the way I think about the clinical site now as an anthropological site is there should be an approach to not just education. Education is important, right? Education does get anthropologists jobs sometimes into the healthcare system. Sometimes there are specific requirements that medical schools have around structure, culture that have to be done, and that's the sort of door to into the organization. But I think there is real value right now in research around the patient experience and research around structural barriers to care delivery. If you talk to physicians, structural barriers around care delivery are probably one of the most cited obstacles to providing high quality care. And they may not say it that way. They may say prior authorizations are a big barrier to outpatient care. Right? I may say that having boarders, people who are admitted to the hospital but can't get a bed upstairs and stay in the ED the entire time they're admitted, are a barrier. But these are all structural barriers to delivering high quality care. I don't think there's a field or a discipline or a place or space that understands what that structure and what those structural drivers are as much as anthropology, and how we could get at them in a way that's different, how we could do research to sort of move past some of those places. I think healthcare is really stuck right now. So there's new value that clinical anthropology can create while still confronting this sort of early 80s, late 70s past that maybe sort of live to within biomedicine. At this point, I think that we are being critical by definition of examining the structure of healthcare delivery, but still creating value within that structure, because healthcare systems compete with each other. Physicians have to live within them, and patients have to have healthcare outcomes in them, right? So all those places are spaces where I think we can create value. And I'll just put a plug and offer here too that I think anthropology is one of the few fields that doesn't have a well thought out translational approach to the work we do. So, I think about the fact I work with psychologists all the time in healthcare settings, and there's very traditional academic psychologists, right, who don't do the work of delivery of healthcare or don't do the work in the clinical space, but there are plenty who also do. Physics is another great example of a field that does this, right? And I would offer that there's plenty of theory and methods that evolve in the applied physics, the applied science of physics, right? While inventing, the space launch or something, right? There's plenty of theory that evolves there. So I don't think we should hold ourselves away from entering into these kind of organizations that might allow us to do this type of work, which also there's the medical school itself, right, which is obviously a clinical site, and the hospital that may be attached to the medical school that are clinical sites, but there are a lot of external players here as well. So I mentioned, two, CMS and Leapfrog. I saw somebody on the chat was from AHRQ. These are all external organizations that really impact a lot of healthcare. I see there's a chat. I'm just going to pull it up. They impact a lot of healthcare as we go on. Okay, there's the introduction, so I'll just keep on moving. So I think we should not forget those places as spaces that anthropologists can also live and make impact. So when we think about anthropology education, one of the things that I really challenge my own anthropology faculty with is that it's not just you and me, right? It's not just the undergraduate medical education. There may be a clear space and a clear role in the undergraduate medical education space, but it's not just you and me. What I mean by that is our residents need curriculum. Our residents also have requirements around structural determinant training and cultural, what we used to call cultural competency training. There needs to be a space there. And then I'd also offer, I think faculty need to learn how to do this type of work as well. There is growing interest now in faculty doing research with mixed methods and qualitative methods and with social questions as social medicine sort of rises again to sort of meet these demands that I've laid out from external organizations on medicine. So we should look to other spaces, not just undergraduate medical education. Another thing I would say too is it's not just us educating medical providers. I think there's, and I'll come back to this in the last slide, I think there's some, and it's great that Dennis mentioned these kind of core competencies, right? There's some core competencies we might want to integrate more into the anthropology curriculum as we move forward. So don't underestimate the opportunity to be involved in graduate medical education, even if it's even if it's looking at doing grand rounds for residents, or doing research projects with residents and fellows and faculty. It's an important space to live. And then I kind of put these two big research paradigms into two big buckets, right? There's where I sort of started with the value in patient experience, right? How can we learn more about where that disconnect is between what the patient experiences and what the healthcare that is delivered looks like. Some of that's the old Kleiman model. Robbie and I really tried to reframe a lot of what is really just traditional participant observation around this idea of patient shadowing. And we did that in the course that we taught as well. We basically took undergraduates, pre-medical students, and had them follow patients for long periods of time. And what we know from longitudinal data from those students is they still do have that lens around what the patient goes through as they try to go through this fragmented system. So I will offer too, as an example, that we develop methods and theory even while we're doing this applied teaching work of undergraduates in this concept of patient shadowing. And then and I'll get to triple aim here in a second, because I do think the triple aim has opened up a lot of this opportunity for anthropologists, but there's value in applied research. A lot of what I do now, and a lot of what our other, we have three other faculty anthropologists besides myself in the Department of Emergency Medicine. There's 4 of us in total. And then we actually have some borrowed time from another anthropologist as well. So there's a lot of us. And what we've really tried to do is rethink how healthcare pathways are developed and delivered by using a concept we sort of framed as ethnographically informed care. So what does that mean? I'll give an example of my first PhD student, Heather Henderson, spent about 2.5 years in our ER getting a sense of what the opioid epidemic looks like, and what that looked like to both patients, and what that looked like to providers, and what that looked like to healthcare administrators, and what that looked like to patients' families outside of the ER. And then from there, we asked the question, can we use that ethnographic information to construct a new patient pathway for those patients? And just a quick medical background on that patient population, it's one that really is under reimbursed, right? There's not a lot of reimbursement around that patient population. It's not like doing a open heart surgery, right, or a brain surgery. So if there's in the structure of what we live in, if those things aren't there, if there's not a clear code to get revenue, then the likelihood of a pathway being developed for that patient that's clean and not fragmented, it's unlikely to happen. So how do sort of you assemble these types of new patient pathways? Well, you have to understand the limitations and factors that pull out new pathways, new pathway experiences, versus those that sort of push against and leave patients really invisible to you while you're doing medicine every day. So if I'll give you examples. These are examples of ways that the anthropologists, I think, can advocate in the applied space. If the National Quality Foundation, NQF, gives a new metric to CMS that has to do with payment, well, all of a sudden, we're going to be very interested in developing new pathways to really make sure that the hospital, the healthcare system, is performing well in that metric. So patients who enter into the space, the clinical space, and are going to be pulled into these new pathways to help meet that metric. So if that doesn't exist, things are not as seen. Things are fragmented across the system. How can you reassemble those things in a different way? I think the anthropological understanding of where those facilitators might sit that are maybe unseen, where unseen levers might sit, may be a really innovative way to do it. It's been innovative for us, and it's worked well in the sense that we were able to build a pathway for opioid use disorder, scale it up, hardwire it, and really let it run in a way that those patients become just as visible as the patient with a myocardial infarction, a heart attack, or a stroke. And so I think that world is wide open right now for anthropological research and applied anthropology. Come back to this. I mentioned this earlier. There's undergraduate medical education. There's graduate medical education. Undergraduate being in medical school years, and then graduate being the residency years. You can see that both the undergraduate medical education and the graduate medical education both have requirements, rules, and other competencies that have to be met for this. These are all spaces that traditionally on the LCME side, that's who accredits the undergraduate medical education, anthropology medical to kind of sneak in. But I think GME is another space that is not as well tapped. I mentioned that we do develop theory and methods as we create these anthropological ways of thinking applied in a clinical space. So I don't think those are binary in any sense, and they're not mutually exclusive. The AAA is really the front door entryway, I think, to anthropologists in the clinical space. People don't know how to meet this new paradigm of healthcare delivery. So this is over a decade old now. We've been operating the AAA model, which is really a consideration of not just so before just deliver a lot of healthcare, right? Deliver more healthcare, get paid more, deliver more healthcare. The AAA really looks at things from the lens of population health, the experience of care, patient experience, and the actual cost. Trying to figure out how those things sort of meet in the middle and drive new structures to be created is wide open. And then each of those little triangles are spaces for new opportunity as well. Over on the other side of the screen, you see this other concept that's gotten a lot of traction, which is called the quadruple lane. And what that does is just the triple lane plus the provider experience as well. There's a massive epidemic of provider burnouts, or at least perceived provider burnout that is going on. And what the healthcare provider, and this is a traditional anthropological question, right? What the person who delivers care looks like, what the shaman looks like, what the healthcare provider looks like, what the doctor looks like, what that person looks like in the current system, right, is an important question right now to medicine. So I think that where we are different from the 70s and 80s is that the theory in anthropology, right, has changed, right? So we integrate a critical lens, we integrate a structural lens. We don't always have to invoke culture, but we can because there's culture creating all those different encounters. But also medicine is really asking for some help right now. Medicine is really not sure how to deal with this new paradigm. So again, you can live in patient experience in different ways. Hospitals have formal roles for patient experience. There's external organizations that are dedicated to patient experience. Leapfrog is one of them. Hospitals all have patient experience offices and officers. I think patient experience is a really untapped role for the anthropology graduate of even a BA degree that could be really solved. It's basically ethnography every day and trying to improve the patient experience. It's a place where I think we could do a lot of work in, and there's journals dedicated to this as well. We could publish in more also. The Barrel Institute is one of the big patient experience institutes. They offer grants, they offer jobs, they offer a lot of white paper and sort of industry expertise as well. Just places where anthropologists may not traditionally think to look at, but do affect the clinical system of healthcare delivery quite a bit, and offer a space for us to educate and ask research questions and potentially be employed, which is what this example is here. IHI, of course, is a gigantic driver of Institute for Healthcare Improvement, a gigantic driver of this new paradigm of triple aim. Also a great space, I think, to think about where do we get research questions that add value? How can we tie our research questions into ways that add value? How can we find new employment opportunities for anthropologists living in this space as well? And just some other third-party organizations that massively impact healthcare delivery, the structure of healthcare delivery in this country. So I think that in general, physicians don't know what to do with special populations and vulnerable populations, but we know we have to do something. Healthcare doesn't know what to do with these populations. They don't pay well. They don't have a lot of people who are trained to see them. A lot of people don't necessarily want to see them, and sometimes that lack of want to see them is because people don't have the tools. There's not an easy medicine to prescribe. There's not an easy procedure to do for these populations. What we have learned is that pairing social scientists with physicians, pairing social scientists or integrating social scientists into our clinical system for these types of populations has really helped us improve their care delivery and even their healthcare outcomes. So we know that disease risk and healthcare outcomes are largely driven by structural and other social factors. Just in some populations, they're more driven by those factors than others, right? So the role of genetics in a lot of disease states is very minimal compared to the role of poverty. And these are not things that physicians are very good at getting at on their own, but it doesn't mean they don't have interest in doing so. So there's a lot of opportunity, I think, for these partnerships to exist. They just don't exist structurally very well right now. And I think that's where there's some movement we could have to come in the door, especially when there's things still going back to climate, when there's illness without a formal organic disease that's not well understood. And the field of addiction and psychiatry is largely an interplay and a tension between those two things still, with a lot of phenotypic plasticity. So therefore a lot of space for anthropologists to sit in. And so much of the work that we're doing with the graduate students at USF and applied anthropology really sits in these populations and trying to close the gap, I would say now more in a more complex way around not just the position gap, but again, the gap delivery as a system, and then both patients and physicians and all the players in that system and how that gap exists. So it just got more complex than Kleiman, but the question is still very, very relevant, right? It's just a much more complex version of the same question.
Jason,
Again,
we're at 12:50.
Yeah.
Just to let you know, we're at 12 o'clock, 50 minutes, 12. All right.
Okay, I'm going to take 2 minutes and then I'll just wrap up for whatever questions or whatever else then. Is that okay?
Sure.
Okay, so just wrapping up here. So I just want to point out there's a lot of opportunity, I think, being introduced now by these external players in healthcare system delivery. CMS, again, just introduced a new metric, SDOH 1 and 2. Again, when these metrics show up, these are things that hospitals will try to scramble to find expertise to fit. And again, these are things that traditionally physicians don't have a lot of expertise in, but offer a lot of opportunity for anthropologists, I think, to work in that space. So translational, right? We can find ways to close the gap between the purely academic anthropologist and then a lot of, say, what psychologists and physicists are often doing. Still develop theory. You've seen ethnographically informed care. We've used it over and over again now. Opioid use disorder. We're using it now to figure out how to maybe craft a pilot around improving gunshot wound secondary trauma. And then, using these applied approaches. My own work was in syndemics and actually taking a syndemic description of Hep C and opioid use disorder and building a syndemic intervention about co-locating treatment for those two things. While we're still pushing theory, right? You can still ask questions about ritual, and you can still ask other very traditional anthropology questions. What is the role of the provider in a structural cultural system? And then the role for qualitative work right now is huge. NIH applications almost uniformly will ask how you're going to get a qualitative approach out of this. And I think that is something that anthropologists can really step in and do. The VA is recognizing this quite a bit. There's over 50 or 60 anthropologists employed in the VA. And sort of as an ending here, I think one of the competency spaces we can maybe improve on in anthropology is healthcare quality, right? Can we up the game a little bit and understand how healthcare quality works and some of the just general principles around clinical operations? How does the clinical space work? So I can ask questions about the clinical space. Patient experience is wide open space, I think, for anthropologists to exist in, which would also change the research questions over time. And then probably having a just general understanding of how clinical trial design works is important, as well as really becoming the expert out there at mixed methods and qualitative design. And just point out there, the VA has a lot of opportunities for anthropologists already. So Dennis, I'll stop there and see where you want to go with it and see if there's questions.
All right, very fine, Jason. You really detailed quite a significant experience you have and shared with us, and the precision you have on where anthropology can go and how we can be really much more effective. It's your presentation's really outstanding. Thank you. So if people have questions, you can raise your hand, and we can go from there. Or someone can just speak up if we don't have any hands up.
Okay, I see a few. I'll just go from the back. It's the rapid ethnography approach. Yes, we are familiar with the rapid ethnography approach and have looked at this approach before and actually do offer some of these articles to when we have limited time and space for things. Of course, it's always nice if you can do some deep hanging out first, especially these very complex questions, but you don't always get that sense or chance. Moving up here, the specific theoretical social determinant approach. Yeah, I think utilizing, yeah, Carolyn, I've seen this approach before. And I think utilizing I think where people really struggle with right now in medicine is getting past the assessment of SDOH phase to the what do we do about SDOH phase. And I think having those frameworks is helpful for that, because that's where we're really stuck, right? It's far away right now from those two things.
Such a great presentation, Jason. Thank you so much. I'm so thrilled to see clinically applied medical anthropology still, that term still being invigorated, because it is about getting med-anthros into the clinical space. And I was so grateful that you mentioned research, because it's hard for med-anthros to get through an IRB. It's hard for them to get, person of interest or whatever status in order to do that deep hanging out, as you've described, that you and Dr. Bear set up for either pre-meds or med student undergrads. And it's crucial, because if they don't see the space created by people like you at that moment, then they won't create it themselves. And I think that's what leads to burnout. They don't get burned out because they don't have the right pens, or sometimes even if they don't have the right formulary, they get burned out because they really do see their patients suffering and they feel like somebody else is not doing their job. So any other further comments on how to help people approach? Yeah.
To that point, we in medicine, for academic faculty, they're often encouraged to partner with bench scientists, PhDs, to get better at research. I would offer that we forget to partner with social scientists sometimes. So please go out and partner with physicians. They need your help. They don't know how to do this kind of work on their own. I mean, faculty physicians, right? I think a lot of times you will find people who really would like to do this type of work, who haven't seen it outside of maybe public health models, and who will jump at the opportunity and give you the clinical space you're asking for too. Dennis, I see hands, but I don't know if I'm moderating or if somebody else is moderating the question.
Yeah, we got Lashman.
Hi, thank you so much for this presentation. I just finished 4 years of the MD curriculum at Rowan. So, all of this is pretty fresh in my mind. My issue, I think, and I'm asking you to consider, is how do you grapple with the integration of the knowledge production of anthropology in the clinical setting? Because I see that for a lot of physicians who are writing these mixed method aims and so on, they just put in, okay, we're going to do some interviews and that's our qualitative. And it's really not sinking into them the depth and the complexity of how we produce knowledge in anthropology. And that's coming out, one, in their research aims. My brother-in-law was submitting a grant and he was talking about it. It was at a very superficial level. And then in the medical education lens, I remember our scholars workshop. So that's the biostats and all of that in preparation for USMLE, right? And they had the most simplistic definitions of ethnography, of epistemology, right? And the facilitators themselves weren't properly qualified. So I jumped in, but then I realized that my perspective wasn't enough to, or it wasn't the right one to address the learning objectives to fulfill the USMLE, right? And so like the way that these medical people approach anthropology and qualitative knowledge is still, I feel like there's a disconnect just based on my past experiences. So can you comment on that at all?
Yeah, so I think you're correct. There is a disconnect, and I'll sort of say there's sort of two things happening here, or two things you can do. So one is you're 100% right that a lot of times people are going to just grab somebody who can do the qualitative methods and say, do the qualitative methods for me, check the box, right? And they think we're done. One way to approach that, I'm actually going through it right now with Daniel, who's on this call. You can also sort of fulfill the mission that those researchers need to fulfill, while also sort of integrating, I don't think sneaking in is quite the right word, but kind of, right? The actual anthropological question you actually want to ask. So you'll still get the information they need clinically or to drive that research question. But there is a pretty easy way, I think, and I got pretty good at this doing clinical trials for a long time, because we would have med students and residents and things who need to do research also. So the clinical trial would kind of operate, and then we'd sort of do other things on top of it, right? Because you're sort of already getting the data and you're already in that space. So what can you do with that? And I think there's a good way to create other knowledge production out of that thing that's already happening anyway. And so that does, I think, work. I mean, we're trying it right now, and it's worked before. So that's one way to get at that. To your second question, that's a structural question, and that's kind of what I'm getting at, right? We have a lot of work to do to change structure, because there's a clear misperception about I think if you ask people what the role of anthropology is, and so you're going to think it's going to be one of two things: either it's cultural competency, right? A static, term that's obviously doesn't fit or work at all, or maybe it's the person who was the one of the faculty members in anatomy, right? They're going to kind of put in one of those buckets. And so I think it's our job over time to integrate the space and be on, right? If you're not writing USMLE questions or you're not in a position like that, then it's going to be hard to make that change over time. So the more partnerships, the more external organizations we work with over time, the more I think that changes.
Thank you. We've got a few things on the chat. One from Dana Kitcher. I just want to put a plug in for cultural safety as a lens I'm hoping more clinically applied anthropologists will adopt and use to address health inequities and disparities. And then from Carolyn Smith, she can relate to your comment on a personal level. She took time off from work to care for a parent, and there was a serious burnout and an awareness that there could be better, more useful systems put into place, and the roadblocks was having no energy to think about or try to implement a new way of doing things day to day at home. And then let's see, there's a question. Is there any work on patients as ethnographers?
That's a good question. I don't know. Anybody on the panel? Anybody here now?
Robbie does.
Robbie knows it all.
You gotta unmute yourself.
Sorry, Robbie doesn't have an answer to everything, but I do want to put a plug in for anthropologists just to be assertive in creating those partnerships with physicians. I did this for many years in Mexico with Javier Garcia de Alba, and Javier hung around with me. He was a physician trained in public health as well, and ultimately went and got a PhD in anthropology, studying with Luis Vargas in Mexico City. And Jason and my relationship started years before that, but I think hanging around with me again more recently was the final push for Jason really to move over and get that PhD finished. And I think if anthropologists reach out and engage with physicians, there are two advantages. First, they can get you into that space. You can't get in there by yourself, okay? And secondly, you can offer them the research tools that you have to help with the kind of stuff they're doing, okay? Possibly solving some of their problems, or if they need, a little research box checked off in their little universe, you can help them do that also. You go in as a partner and you find that people discover how useful anthropology can be in those spaces, and it grows and grows and grows. I mean, what Jason and I did started, it was like, our model initially was build a better bear, build a better doctor. How can we do this? And the whole thing took off and got bigger and bigger and bigger. I'll put in another plug also for a space that I am currently working in, having retired from USF. I'm an interpreter in a free clinic. And that's a really amazing space to be working in terms of social determinants of health. But it's also a very interesting space where I find that the physicians come to value not only my expertise in translating Spanish and English, but all the cultural pieces that I can just toss in to that space. Now, that's not a place where you're getting paid, but again, these are ways to make connections. And our medical school runs medical students through that free clinic. It's another way where an anthropologist can become a valued partner of physicians. If I wanted to move further into family medicine, I could do that with ease now because those physicians already know that I have something useful to contribute, if only in the free clinic space, but that could be broadened out. So anthropologists on the call, go out there and be assertive. Do this, okay? You can do this. You can get into those spaces. You do have things to offer, and people will be receptive, at least in my own experience.
Thank you. Carolyn had her hand earlier, but she also put a comment on the chat. You want to?
Yeah, I did. Dr. Wilson, would you please just say 3 words about your ample social media and public media outreach? Because I think it's so relevant to what you're trying to suggest clinicians can do.
Yeah, I mean, after this afternoon, I'll be on talking about heat illness, for the local news, which is really a way to talk about the inequities around climate change, right? I mean, you have to find the only way to learn way to get that in is like to do these things a lot, right? I mean, obviously you kind of learn you can do this stuff as well. But yeah, the translational space in public anthropology and public medicine is critical, right? To let people know what it is we're doing and to have a voice that sounds different when you talk to that audience, right? And another audience as well.
Julia has a comment.
Hi, everyone.
I
was listening with a lot of interest to what Robbie was saying about anthropologists needing to be assertive when they participate in these spaces. And I just wanted to share, I will post it in the chat now, but I wanted to share an amazing reference that talks exactly about this and reconstructs how questions coming from clinical practitioners can be reframed in useful ways by anthropologists. I think it is so important for us to be able to ask questions in different ways. And there are different ontologies and epistemologies that are at stake usually when anthropologists are working with clinicians. And it's interesting to look at how the dialogue between those two parties unfolds and how that ultimately allows the research to be done at a deeper level. I'll post the reference in the chat now for everybody.
Back to that knowledge production question. I mean, that's where the knowledge production happens, I think, is in that conversation and the working of together, because you are forming a new unit and a new way to see the world together that didn't exist before. I think that is the knowledge production that happens.
Thank you. We do have a comment on the chat from Jerome Crowder. We have had good responses from undergrad MS as introducing structural competency in our clinical methods course and helping students recognize the historic issues regarding race and outside of the clinic. As most of our students are underserved, they recognize how the systems have hurt them and their families. That helps them to recognize how they can affect the system once they are in the clinic every day. They say that just understanding that there are systems they are part helps them help the patients beyond their medical knowledge.
Yeah, I think the only frustration the students have with us sometimes is what do we do with these things, right? And I think there are anthropological things we could do. There are interventions, right? And I think that's what our syndemic intervention has been about. But I think that's gonna be the next challenge that we can offer is where's the intervention and how do we get at some of these structural things we're showing. And and also I will offer too, with medical students, this is so important because sometimes the experience they have is very much not underserved, right? It's maybe a little bit different than that student population. Sometimes medical students have a aha moment when you show them a structural, when you actually take them through a structural exercise, right? And they sort of see how much this comes into play.
All right. Richard, do you see any other questions there? No.
Oh, last thing is the reference posted by Julia.
All right. All right, Jason, I'm really proud of what we've done here today. You've really set a course for our interest group. We're relatively new, and we've had some excellent presenters prior to you, and each one has focused on a different aspect of anthropology and health professions. And your detailed analysis, specifically at the clinical level, is very valuable, and I believe you're kind of help set us a course on where we can go and the priorities we can set here as a professional organization. So I thank you very much. Those who are in attendance, we're going to turn the recording off now, and then it will become a conversation with Jason and others in a much more informal way. So let me do that.